Yes, that's it. Okay, we start now.
انا بس عايزه اقول لك يا كريم، المره اللي فاتت كانت اول 5 دقائق ميوت في الميتنج. كريم
احنا لايف دلوقتي على الفيسبوك يا دكتوره هبه. We will open room now for attendee, okay?
Okay.
Can we start?
Yeah, I'm fine. Heba, unmute.
Hi, everybody who may be watching us from all over the world. Good evening, good afternoon, and good morning. It's 10 p.m. Cairo time, 9 p.m. UK time, and 4 p.m. USA time. I would like to welcome you all to our second international webinar of the Memorial Institute Kids Eye Center. But before going deep into our webinar, as all our previous webinars, we'd like to send all our greetings, respect, and warm feelings to all our the doctors and our colleagues that are fighting the coronavirus pandemic all over the world from inside and outside Egypt. Today we are very excited for tonight's meeting, not only because we gonna learn about the a lot about the medical and surgical strategies of the glaucoma, but because we think about the pediatric glaucoma as a project. We are planning, working hard, and dreaming of providing the highest quality, the rapid, the effective, the available, the efficient medical and surgical treatment for the pediatric glaucoma for all kids from all over the world who cannot afford the treatment with the cheapest and even free service. I hope one day this free ward behind me to be full of the pediatric glaucoma kids who are having the highest quality and the effective medical and surgical treatment of the pediatric glaucoma. Today we have very special eminent stars of the pediatric glaucoma, starting with our Egyptian star, Professor Dr. Tariq Sharawi, the president of the International Society of the Glaucoma, and it's an honor to announce that Professor Dr. Sharawi is the advisory director of the glaucoma project, pediatric glaucoma project and unit in our mic. We have also Dr. John Brookes from Moorfield Eye Hospital, UK, and Dr. Albert Khouri from USA Roger Hospital, and our pediatric glaucoma speakers, Professor Dr. Hani Salah Nasr, Professor Dr. Ahmed Dwidar, and Dr. Nader Mumtaz. And we have on the board also Professor Dr. Muhammad Salah, the founder of the MIC, and my colleague Dr. Ayman Ghanimi and myself. You can watch this video through the Zoom platform and even through the Facebook live stream, but we encourage you all to join and watch the video through the Zoom for all of you to engage with us with your questions and comments. And we have a very special request from all of you to leave your questions in the Q&A box and not in the chat box, for all of us to follow and answer you live or even by texting. And I invite my colleague, Professor Dr. Ayman Ghanimi, to present the speakers. And before he presenting the speakers, I'd like to present to you all my colleague and co-moderator, Professor Dr. Ayman Ghanimi. He is a consultant of ophthalmology since 2003, and he joined the Mayor since 2015. He had his fellowship in the Maghrabi Saudi Arabia and in the Bascom Palmer, and he joined our Mayor since 2015. And I invite Dr. Ayman Ghanimi to present Dr. Muhammad Salah and rest of speakers.
Hello, thank you. Thank you, Dr. Ebert, very much. I would like to welcome all of you, all the speakers, and we are very excited for this night. And again, I like this picture very much. This where everything started. It's like 1 year ago now, with this nice meeting with Dr. Tariq Sharawi, Dr. Dwidar, and Dr. Heba, when we started to put the first lines in the congenital glaucoma unit in our Memorial Institute. So let's get back to things when things started. Things started with an idea with Professor Dr. Muhammad Salah Za'atar, who was the former Dean of Memorial Institute and the former President of the General Organization of Teaching Hospitals and Institute. And actually, he is a godfather and founder of the Mike Memorial Institute Kids Eye Center. We started everything from scratch together, and with the idea of Dr. Muhammad and with a hand with me, Dr. Heba, and all the other team, we started everything from scratch, wall by wall, brick by brick, and floor by floor. Everything started from the beginning till things started to shine, and then started to have this lovely building with this lovely garden in front of it. And now we are entering inside the building. We can see here in the reception of the building, you can see the vision, mission, and values, and this very nice logo. We have general clinics, 6 general clinics, a specialized clinic in all the pediatric ophthalmology subspecialties, strabismus, retina, cataract, oculoplasty, electrophysiology, neurophysiology, pediatric genetic clinic. Here's some picture of this, and there is one very important subspecialty clinic we will never forget, the pediatric glaucoma clinic. It's a very important clinic, and we are targeting that it will have a very, very good job in helping children with glaucoma. We have also the investigative units. Now let's take the elevator for the next floor. The inpatient, we have 25 beds, a big partition for patient for free, they're not paying anything, and a part for economic and low-paid patients and some private patients. Here there's some pictures you can for those like the Smurfs, and this is the inpatient part. With lovely colors, and we tried as much as we could to have it child friendly. And then the last floor is the OR. So welcome to the mic. So now the first one I would like to present is Dr. Muhammad Salah. He had some technical error, unfortunately, and he couldn't join us now, but we have to speak about him. Dr. Salah is one of those who has the hope and vision and clear vision for the future. He was the dean of the Memorial Institute from 2014 to 2018, and the president of the General Organization of Teaching Hospitals and Institutes from 2018 till 2020. And he had a great vision in the institute to build it up. So I'm welcoming Dr. Mohammed Salah, who couldn't be in, but I would like to thank him for his vision, thank him for following everything till now, and till we reach the vision of our institute. Now, Dr. Ebe, you can, if you'd like to take over, and would like to introduce the other speakers for tonight. Yes, our big star. Oh, the lovely picture.
Unmute Dr. Heba, please.
Yeah, I think now you're unmuted. You can start talking, Dr. Heba.
Okay.
Yes.
I hope my voice is more clear now.
Yeah, it's very clear. Yes.
More than the introduction. It's a great pleasure to present my lead professor and our Egyptian star, as I told you in my introduction a few minutes ago. Dr. Tariq Sharawi is the president of the International Society of Glaucoma Surgery and serving as a member of the board of governors of the World Glaucoma Association. It's a pleasure to tell you all that Dr. Tariq Sharawi, one day he was in the memorial, he was an ophthalmologist in the Memorial Institute for ophthalmology, for ophthalmic research when he was young, I guess. Dr. Tariq Sharawi.
He's still younger.
Dr. Tariq Sharawi is the president of the International Society of Glaucoma Surgery and serving as a member of the board of the governors. And as I told you, he's the head of glaucoma unit and the glaucoma surgery research group at the University of Geneva. And it's a pleasure to announce that Dr. Tariq is the board member of the Memorial Institute Research Center and Training, and he is the advisory director of Pediatric Glaucoma Unit at the Memorial Institute Kids Eye Center. Dr. Tariq Sharawi, his main research interest in the surgical techniques of glaucoma, especially in the developing countries, and he is an editor-in-chief of the Journal of Current Glaucoma Practice. He also serves as the editorial board of many ophthalmology journals, including International Journal of Ophthalmology, Journal of Glaucoma, Canadian Journal, Middle East, African Journal, and the Asia Pacific Journal of Ophthalmology. In addition to his glaucoma practice, Dr. Tariq is an active participant in a number of the projects in dealing with global prevention of blindness, and he is a founder, a member of under the board of trustees of the Baladi Foundation, which is a very, very important experience. He will talk to us about his experience in the Baladi Foundation. Also, Dr. Tariq gave the Memorial Institute for Ophthalmic Research a lot of visits doing surgeries and treating glaucoma patients, and he share a lot in our scientific activities and the conferences, and we always are very happy to have Dr. Tariq Sharawi among us, treating the patient and teaching all of us a lot of things. And it's an honor to announce that he is the advisory director of the Memorial Institute Kids Eye Center. He took the issue too seriously and want to make a great project of treating all pediatric glaucoma patients from all over the country. And now I invite Dr. Tariq Sharawi to present Dr. John Brookes and Dr. Albert Khoury to all of us. Dr. Tariq.
Thank you, Heba. I'm very humbled by all what you've said, and I would have been happy if you just said my name without all the things around it. I'm not going to go into details of explaining who Albert Khoury is or who John Brookes is, because that would be almost impolite from my side to speak about those two great glaucoma specialists in details, because I presume that you know very much of all what they have done. Albert and we go a long way together. I observed Albert rise to stardom in the United States. I've seen him going from starting into his fellowship program all the way to becoming director of the glaucoma division, director of the ophthalmology residence in Rutgers. He actually inherited Rutgers from Bob Fechner, a very good friend of mine as well, and I guess one of his mentors. It is a great success story from from my favorite Lebanese. I've learned a lot from Albert's work. Albert is extremely dedicated to his residency program, I have to say, and he is training a big number of young people that are going to be definitely stars in the future, in the coming future years. John Brookes is, I mean, I've known John from probably 15 years ago or more, when John became the new face of the congenital glaucoma unit in Moorfields, the major consultant there. The unit for congenital glaucoma in Moorfields has a world-renowned reputation, having produced excellent consultants around the world, and trained so many people, following in the footsteps of Penco. Big shoes to fill, but from what I have been observing over the last decade or so, John has been able to actually lift his unit to higher levels, and his experience and his compassion for children, which is mainly, I mean, this is his main specialty. I mean, let's agree that many glaucoma specialists do congenital cases, but John has dedicated his life specifically to congenital glaucoma cases. So it is really a great honor, and I really thank them from the bottom of my heart that they could join us in this specific and very special webinar to announce a big new establishment in the field of congenital glaucoma, I hope. So the whole issue of us being here is not just to teach, but also to celebrate something that is unique and special, that just comes out now and is a newborn. And I don't think it's an Egyptian newborn. I think it's going to be a global player. So I thank John and Albert for having graced us with their presence today, and I'm very much looking forward to listening to both of them.
Thanks, Dr. Tariq, for presentation of Dr. John and Dr. Albert. And I'd like to welcome Dr. John and Dr. Albert to our meeting today. It's a pleasure having you in our meeting. And now I'd like to present to all of you Professor Dr. Hani Nasr. Professor Dr. Hani Nasr is the CEO of the Memorial Institute Research Center and Training Center, which is a new big research center, including all the research projects and training programs held in our institutes, and also the genetic lab and the clinical genetics unit, which we launched a few months ago. And he is the former head of the General Organization for Teaching Hospitals and Institutes, and he a former dean of the MURA before Professor Dr. Muhammad Salah. Dr. Hani had helped a lot in the development of the ophthalmology in the general institution, general organization as a whole, and in the Memorial Institute with Dr. Muhammad Salah in all the developing stages of the Memorial Institute we talked about in the previous webinars. And he is the chairman of the Committee of Ophthalmology in the Egyptian board. He is a member Egyptian GMC since 2017, and he is a professor of ophthalmology since 2005. he has a diploma in the hospital management from Harvard University at 2010. Now I invite my colleague, Dr. Ayman Al-Ghanimi, to present Dr. Ahmed Dewdar.
Well, thank you, Heba. Well, it's a pleasure to introduce my dear friend, Dr. Ahmed Dewdar. Well, Dr. Ahmed Dewdar, I know him a long time ago. He's a consultant glaucoma in the Memorial Institute. Dr. Ahmed Dewdar is a former assistant consultant of Glaucoma National Guard Health Affairs in Riyadh and former glaucoma specialist at King Abdulaziz University in Riyadh. And they got the best teacher in resident training program in 2014, the National Guard Health Affair. And he got his FRCS from Glasgow 2005, and this is from where our friendship started. We have met there back to 2005 in our exam, and we succeeded together, and since then we are deep friends. Dr. Ahmed Dewdar is doing a very good job in the Memorial Institute, and he's also had a special interest in the pediatric glaucoma, and he's doing a very good job in pediatric glaucoma in our institute, and definitely, yeah, he's with us in the new start and new beginning in the pediatric glaucoma unit in the MIC. Welcome, Dr. Ahmed. Now, next, I would like to, I'm feeling happy to introduce our energetic person, Dr. Nader Mumtaz. Dr. Nader is a glaucoma fellow at the Memorial Institute. He has MRCS Edinburgh since 2019, fellow of the ICO, has a master's degree from Cairo University. He is interested, of course, in the management of adult and pediatric glaucoma, and recently published some papers in the beginning of his life. I'm really proud of him. He is always making us all proud of him, and all the time I'm happy to work with him. I really feel comfortable. I really feel energetic when he's with us. He's doing a very good job, and I'm happy that he will present a very nice presentation in this webinar. Welcome, Nader. And then my dear colleague, Dr. Heba Mitwali Dawan. We are starting together the journey from the very beginning. Dr. Heba also is a board member of the MIC. She's a consultant pediatric ophthalmology and strabismus. She has also, she sure has her MD, her FRCS, and she had her fellowship in Maghrabi Eye Hospital, and she joined the Mayor in 2012 and started the pediatric ophthalmology in 2013 at the Memorial Institute. Till I joined her in 2015 at the Memorial Institute, and since then we're doing a very good job. We are building a very good team. It's always my pleasure to work with Dr. Heba, and thank her for her efforts in preparing this webinar. She did a marvelous effort on this. Thank you, Dr. Heba, and welcoming you.
Thank you for all, and thanks for the nice words, Dr. Ayman. And now I invite Dr. Tariq Sharawi to share his screen. I will stop sharing my screen. Dr. Tariq, the platform is yours. Go ahead and share your screen.
All right. Does that work? Can you see and hear me?
Yes.
Yeah.
Very good.
Yes,
Okay. So a real pleasure to be here with you tonight. This is a webinar to mark the beginning of a new chapter in childhood glaucomas within Egypt, I hope, and with the potential to shed light and to teach and to provide better care for people from Egypt, and I hope from the whole region. Childhood glaucomas for me has always been a passion, and this passion actually started when I was a young resident in Cairo some years ago, not too many years ago, and as you can understand, the national problem of congenital glaucomas in the Middle East is nothing to compare with what we see in Europe. In Europe, we see in a country of 8 million people, something like 8 new cases per year. When probably that is the same number that that Egypt or Saudi Arabia would see per day. You can see the incidence is significantly higher in Saudi Arabia or in Egypt compared to Switzerland, Germany, or the UK, with the exception of the Roma people in Romania who are associated with the highest number of congenital cases known. So my experience with congenital glaucomas come mainly from my practice in Egypt, because I don't see too many of those in Switzerland. As I said, there are very few. But Baladi Foundation in the south of Egypt that has been working for the last 17 years. My work within the Memorial Research Institute of Ophthalmology for many years now, as well as my practice within the Watani Eye Hospital. Among those three places which I visit almost on a monthly basis, I am able to refine my knowledge and my skills when it comes to congenital glaucoma. So I will share with you rapidly the lessons that we've learned working together in Baladi or in the Memorial Research Institute, and speak a little bit about the surgical choices, show you what we are doing, and at the end, listen with you to my colleagues about what they are doing and how gone exclusively to working with Perkins or eye care tonometers to measure intraocular pressure. We believe in the quality of the pressure measurements that we're getting with them, and it really makes our ability to measure pressure much different, and it has decreased significantly the number of cases where we had to go and do examination under anesthesia to measure pressure. A lot of children, young children, can take an eye care tonometer compared to anything else, and it helps us a lot in measuring pressure in those kids. Now, it is very important to keep in mind what is a normal pressure in Egyptian children, and from the data that we have been gathering, we are looking at 9 to 11 millimeters of mercury, and definitely something more than 20 is, of course, pathological. You are all aware of the influence of general anesthesia, so I'm not going to go into details about that. We see a lot of Hubstrai in Egypt. Professor Hub actually was a Swiss ophthalmologist, and just wanted to remind you that not every case of Hubstrai is pathognomonic for congenital glaucoma, and we have published a series of isolated Hubstrai cases, 24 of them, that we have been following for up to 10 years, and transformation into glaucoma happened in 40%, while 60% of cases remained with normal pressure, normal optic nerves, and have not obviously developed to become. It is highly important in our practice to actually record the angle and to do as much teleconsultation as possible. We have the ability now that is not as expensive as before to video record angles and to video record the whole examination under anesthesia, and it helps us a lot to be able to also look dynamically at the angle structures and at the optic nerve, and to come back a few months later or a few years later and compare it. And we can also transfer easily the real time, the recordings that we're making to other places around the world to get second opinions in some cases. These are the surgical options that are available for a glaucoma surgeon when he's dealing with a congenital glaucoma case. And it goes from angle surgery with ab internal approaches that John is going to address, to angle surgery from an ab external or fistulizing point of view, whether we're going to do a circumferential trabeculotomy or a trabeculotomy, or going into a filtering surgery to a trabeculectomy, or like what some people do in terms of implanting and express, something that I find horrifically, something that I do not really support. I go into the school of non-penetrating procedures with a trabeculotomy, and then we have shunts, and finally we can close the tap by cyclodestruction and using lasers, which Albert is going to address. I'm doing a lot of deep sclerectomies with trabeculotomies, ab external trabeculotomies. I think they are safer. I think they offer diffuse and shallow blebs, and part of the bleb is intrascleral, and it gives us an access to uveoscleral outflow. So as you can see here, we really dissect very, very deep to create this intrascleral space and open Schlemm's canal, as you can see here. followed by removal of the second flap, which really doesn't play any role. And then through an easy access to Schlemm's canal, we do a straightforward trabeculotomy. So nothing here that is too complicated. And we have been getting interesting results. I can show you rapidly the first 153 cases that we have actually operated with this technique from 2004 to 2007. And the mean intraocular pressure was characteristically very high, mean of 43 millimeters of mercury, something that you see a lot in an Egyptian population. And at 10 years, the mean intraocular pressure is 16, with a complete success of 43 patients, or 43% of the children having had a good control of intraocular pressure without medications. If you add eye drops, the qualified success goes up to 78%, and about 20 to 22% had to have reoperations and further interventions to be able to improve on this kind of success. But I mean, I've been doing a lot of congenital glaucoma cases for years now, and the only thing that I've learned is whatever I do in the operating theater would never count much if there is not a rigorous post-operative management to keep the intraocular pressure well controlled, to fight for vision. And on that, it's not just my work as a congenital glaucoma surgeon, but the work that I have to delegate and collaborate with a pediatric ophthalmologist, sometimes with low vision aid specialists. Every patient with clear cornea, or every patient that will have a clear cornea, or every patient that can have a better vision if we actually transplant a cornea, all those really deserve an enormous amount of work and an enormous degree of dedication, because once you meet a congenital glaucoma case that you've operated 10 or 15 years down the line, and you see that he or she still has useful vision, and they are productive members of the society, and they're people that can live and can enjoy life, then the reward for you as an ophthalmologist is enormous. In Aswan, we have been working with a scoring system, and this scoring system is distributed for obstetricians, for pediatricians in Aswan, and according to family history, the condition related to the cornea, tearing, blepharospasms, etc. If a score is beyond a certain number, we ask pediatricians and gynecologists and general physicians to refer the children to us, and this has changed significantly our ability to catch cases early on and not just wait till the corneas are completely damaged, which makes our work very difficult. Unfortunately, in Egypt, if the cases don't work, as Dr. Hani Nasr will show you, we sometimes have to go through putting a tube. I'm always wary of the effect of tubes on endothelial cells. A lot more of that you can hear from my colleague, Dr. Hani Nasr, who is an expert in the field. And finally, we are together taking a step forward. And this step has many aims. One of them is the creation of the Egyptian Child Glaucoma Network, a network not just for doctors, but for doctors, for patients, for their families. It's an integrated work. It's a multidisciplinary work to be able to provide the best possible care for a congenital glaucoma case, for a child with glaucoma. This is a dream. I've been working on that for some time. I think Mike, with its excellent staff and fantastic capacity, is my best 50th birthday. I've just turned 50 a few weeks ago, so I consider the responsibility and the honor of being an advisory director of the Mike Congenital Glaucoma Service to be the best 50th birthday present that I had. So thank you very much for having me. It's a pleasure to be with you. And now I shut my mouth and listen to people with better experience. Thank you very much. I'll stop sharing my screen, and I think we go from here to John's presentation. John is going to speak about ab internal approaches to manage congenital glaucoma. John, we could never get a better speaker for this event that means a lot to us. Thank you, John, for being with us.
It's my pleasure. So I'm just going to share the screen. Can everybody see that and hear me?
Yeah.
Perfect. Well, first of all, thank you very much for the invitation to speak here. And I must say that the hospital looks amazing, and I'm sorry that I've not been able to visit it and give this talk in person. But thank you for the invitation, and it's very nice. And it is, in fact, the first webinar I've done, so I just hope things go well. So I've been asked to talk about ab interno procedures, but I first of all thought I would just mention, as if we need reminding, the challenges that we face in dealing with pediatric glaucoma. I also want to mention my own personal preference for dealing with new cases of congenital glaucoma, and that's the circumferential trabeculotomy. And I'm just going to mention some results from that. I'll talk about ab interno procedures and just a slide at the end on what happens when angle surgery fails and we might need to move on to something more invasive like tube surgery. Well, we know that dealing with childhood glaucoma, we have to play the long game. We have to preserve a child's vision for their entire lifetime, which hopefully will be many decades. Traditionally, children with glaucoma require multiple procedures. And the problem is that we know that with every subsequent procedure a child has, the effect in reducing the intraocular pressure, the effect on lowering pressure reduces. So we want to try and limit the number of operations that children require. We also know that with multiple operations, the complications increase. And obviously we want to try and avoid very serious complications like blood leaks, blood infections, and tube erosions. What we want to see are children like this in the upper slide who have a safe surgery, who have very efficacious surgery, which works well after one operation. And particularly when dealing with developing countries and probably in the post-COVID crisis, we all need to think about cost effectiveness. We need to find surgery that is very cost effective as well. And we need to avoid these horrible complications that relate to blebs and tube implants. So what are the factors to consider? Well, I've been asked to talk about ab interno procedures, and obviously the ones that we're mainly thinking about are the classic ab interno angle procedure, which is the goniotomy, and more recently the gonioscopically assisted transluminal trabeculotomy or GATT procedure. We can compare that with the ab externo procedure, which is the circumferential or the 360-degree trabeculotomy. And just to mention other ab interno procedures relating to micro-incisional surgery, or so-called MIGS procedures. There are devices that can be used, like the Zen and the iStent and the PreserFlow and Trabeculotomy. I really would like to try and press the point that we should probably, at all costs, try and avoid using foreign materials and foreign devices in a child's eye, because I've no doubt that they have a much higher rate of complications. And I think when we're looking at devices, I think we really should look at long-term outcomes in adults and long-term risks in adults, and really only then consider using them in children once we know what the safety profile is in these devices. So we should probably avoid them if we can. When we're thinking about MIGS procedures, these are what's put forward as the ideals of a minimally invasive glaucoma operation. Ab interno is an ideal because we're treating the patient through a clear corneal incision. So we're trying to avoid the conjunctiva. And obviously the conjunctiva is a glaucoma surgeon's best friend or worst enemy. And so if we can try and spare the conjunctiva, that would be a great advantage. As in all children, it needs to be minimally traumatic. One of the other ideals that's put forward for MIGS is modestly efficacious, but I think in children, we need to have highly efficacious, again, to limit the number of procedures that children are put through. We need it to have an extremely high safety profile. Monitoring children post-operatively is very difficult. Treating complications in children is even more difficult. So the safety profile is essential, and we need children to have a rapid recovery. And as I mentioned, cost is all important. There are many developing countries where microcatheters, MIGS devices are just prohibitively expensive. When we're thinking about surgery in children, we need to think about what's the appropriate procedure and what procedure has the best chance of working in a particular child. The mechanism of glaucoma is important. And with this, I'm particularly thinking about angle morphology, as Tarek has mentioned. And if we look at primary congenital glaucoma, if we look at juvenile open angle glaucoma, these are the cases that respond the best to angle surgery. We need to think about comorbidity, and I'm particularly thinking about cases of anterior segment dysgenesis, for instance, where angle surgery may not be the most appropriate treatment. And I think in treating with circumferential trabeculotomies like I do in primary congenital glaucoma, and increasingly in secondary glaucomas, the most disappointing results I've had are with children with anterior segment dysgenesis. And perhaps this is not unsurprising, bearing in mind the pathophysiology, in that the anterior segment is not fully developed. We need to take account of other comorbidities such as choroidal hemangioma in Sturge-Weber syndrome, and avoid any sudden risk of hypotony, which risks bleeding. Corneal clarity is important, because if we're doing an ab interno procedure, we generally need a clear cornea to be able to carry out that procedure effectively. Social factors such as compliance are important, because ideally we'd like to have an operation where drops are not required afterwards. And 360 angle surgery often provides that, because many of these children don't need drops post-operatively in the long term, for at least a few years in any case. And we need to look at visual prognosis, because we don't really want to be putting a child through an invasive operation if their visual prognosis at the end of all that is limited. There are very few hard and fast rules in pediatric glaucoma surgery. And in fact, the choice of surgery is very much surgeon dependent, and what a surgeon is experienced with and is comfortable in their particular hands. But I think there are some stricter rules which I put forward for primary congenital glaucoma. And I think the first line surgery has to be angle surgery. We're trying to resurrect the patient's own drainage system. And that's really probably something that most pediatric glaucoma specialists will agree with. Trabeculectomy probably should be avoided in glaucomas that occur following cataract surgery, because they do have very low success rates. And as I mentioned earlier, we need to try and avoid inserting a foreign body into the eye, and try and avoid using devices which have an increased risk of complications. Now, this is the classic ab interno procedure in children, the goniotomy. And I think really this procedure transformed the outcomes of children with congenital glaucoma. And it's testament to the fact that it's been used since the 1940s, and until very recently has been the first line procedure of choice for PCG at Moorfields and elsewhere. And the first goniotomy performed at Moorfields was back in 1947. And really until about 5 years ago was still the mainstay and primary treatment for primary congenital glaucoma, unchanged over many decades. Now, the advantage of the goniotomy is the preservation of the conjunctiva. So that's important, because we can repeat a goniotomy procedure. And if we do need to progress to a further procedure like a shunt, then we have fresh conjunctiva with which to carry that out with minimal scarring or no scarring. It's generally a minimally invasive operation. The incision into the clear cornea is very small. We need to be mindful of damage that can happen to the cornea or the lens, but it's had very good outcomes since the 1940s. And here you can see a typical child with congenital glaucoma. They have very nice clear cornea afterwards. You can see the arbs strive, but healthy optic discs, and many have very good pressure control. The other great advantage is its repeatability. Some would say that's its disadvantage, and when we compare that to circumferential trabeculotomy, we never need to repeat that because the angle's been treated in one sitting. But it's cheap, and there are very few expensive pieces of equipment that need to be used for a successful goniotomy. Similarly with trabeculotomy, which has been around since the 1960s, the great advantage of this is that it can be done through a cloudy cornea. So in many countries where children present later or with more advanced disease, the trabeculotomy may well be more appropriate than a goniotomy, and still a very cheap and cost-effective procedure, and can be combined with trabeculectomy. The thing that changed my practice was the circumferential, the 360-degree trabeculotomy, which I started, been around for a long time, but I started about 5 or 6 years ago. And I think it's transformed my practice, certainly in primary congenital glaucoma, but increasingly in the secondary types of glaucoma as well, which it does also have very good outcomes. And I use the eye track, the illuminated microcatheter. I'm just going to mention this before moving on, just to say that it's really been around for quite a long time, in that Beck and Lynch described the circumferential trabeculotomy with a 6/0 proline suture way back in 1995. But it really was more recently, when the illuminated microcatheter was used, that it took off in popularity, treating the entire angle in one session. So the great advantage is that it doesn't need to be repeated. And when we look at comparisons of trabeculotomy, and these are early studies, that they show that when you compare 360 trabeculotomy to goniotomy, there is a very significant difference. So the first study from back in 2000 shows that the IOP was successfully controlled in over 90% of cases with trabeculotomy, compared with almost 60% with goniotomy. Visual outcomes were much better in the trabeculotomy group, and the prevalence of high refractive errors, which was much more prevalent in the goniotomy group. And again, this was borne out in cases where the illuminated microcatheter was used, where this retrospective review showed qualified success of over 90%. Now, I just mentioned this because this is my primary surgical treatment, and we've just published last month in the American Journal of Ophthalmology a comparison of the transition from conventional angle surgery to the 360 trabeculotomy. And what we did, we looked at our last 52 cases of goniotomy procedures and compared these to our first 54 trabeculotomies. So in theory, what you could say is that we were at our most experienced in goniotomy procedures and our least experienced of trabeculotomies, as we just started this and we're still on the learning curve. Despite that, at 12 months, the qualified success was over 90% in the trabeculotomy group, compared with only 35% in the goniotomy group. And you can see at last follow-up, qualified and complete success was significantly different in the trabeculotomy group. And again, the great advantage is that only 5% of children with the trabeculotomy group required further surgery, compared with over 60% of the goniotomy. And that, in the main, was a repeat goniotomy. So this is why the circumferential trabeculotomy has become my mainstay of treatment, surgical treatment for congenital glaucoma. Now, the GAT, the gonioscopically assisted transluminal trabeculotomy, is in a way similar to the comparison between goniotomy and traditional trabeculotomy, whereas this is minimally invasive. We deroof the entire Schlemm's canal. It's conjunctival sparing. But the difficulty is that you need a reasonably clear cornea to be able to achieve this. And so this is something that I have no experience in carrying out myself. I think there's quite a learning curve with this and a learning curve with circumferential trabeculotomy. And with the ab externo approach, that can be in all cases, whether the cornea is clear or whether the cornea is cloudy. However, it does show good results. And this is a recent paper from the American Journal comparing the trabeculotomy ab interno with a TRAB 360 device. And in a retrospective review of 46 cases, with a median follow-up of 12 months, they're achieving about 70% success rates overall, and over 80% in primary congenital glaucoma. So I think you can see when you're treating the entire angle, there's a much improved surgical outcomes from our previous traditional techniques. Finally, just to mention what happens when angle surgery fails, I would then tend to proceed with a tube implant. And again, at the end of last year, we published our results for the long-term outcomes of drainage device implantation in children within the first 2 years of life. And interestingly, it's come to pass that since our introduction of the trabeculotomy, the number of cases requiring a tube implant has dramatically reduced compared with when we were doing goniotomy, repeat goniotomy, and then going on to tube implant surgery. This study, we looked at just 60 eyes with a mean follow-up of 4 years. Most cases of congenital glaucoma would have been after failed goniotomy procedures. 18% were aphakic and 10% anterior segment dysgenesis. Interestingly, there was no difference in the outcomes between PCG and non-PCG cases, and we were achieving about a 60% success at 5 years. And we generally use the Bearvelt tube implant for these cases. I think the big advantage of tube surgery over trabeculectomy, for instance, is the number of general anesthetics needed in the first year after surgery. 1.8 general anesthetics in our series, whereas in cases of post-trabeculectomy, they were having to carry out many more post-operative anesthetics for routine follow-up, because removal of releasable sutures, injection of anti-scarring agents in children always needs general anesthetics. So tube surgery is much more labor-intensive procedure than trabeculectomy surgery. So in conclusion, angle surgery, always first-line surgical intervention for childhood glaucoma, particularly for primary congenital glaucoma, and increasingly in secondary glaucomas. The 360-degree deroofing of Schlemm's canal offers the best surgical outcome without the need for a further device, glaucoma drainage device. The ab interno procedures does offer the advantage of conjunctival sparing, but again, it depends on surgeon's preference and experience. And I would still prefer ab externo just for those reasons that I've now become comfortable with that procedure. It's carried out in the infratemporal quadrant, so we still have the supratemporal quadrant free if further surgery is required. Thank you very much for your attention.
John, that was really, really good. Thank you very much, and hard to believe that this is your first webinar to do. This was executed perfectly, and I think the amount of information that you gave us will generate a lot of questions. So please stay with us, because I would like the rest of our colleagues to project their own points of view, and then I'm sure that there will be a lot of discussion. I think what you presented needs further contemplation. I'm looking at it with a lot of interest. I think we go to Ahmed now, who's going to speak about ab external approaches. Ahmed, the floor is yours.
Thank you, Dr. Tariq. Well, I would like to welcome all of you and thank you also for joining us. Today, I will talk about tips and tricks in congenital glaucoma surgeries. Just a brief introduction about the congenital glaucoma for our junior colleagues here. We have either primary congenital glaucoma or secondary congenital glaucoma. Usually it's present at birth, or even manifestation may not be recognized until early infancy. This is characterized by improper development of the eye aqueous drainage system, leading to increase in the intraocular pressure. It could be secondary, associated with other congenital ocular abnormalities, or associated with other systemic congenital abnormalities. What we see common is like aniridia, causing secondary glaucomas, with partial absence of the iris, subtotal absence. Usually there is synechial angle closure is 75%. Maybe you have occasional cataract or lens subluxation. Sturge-Weber syndrome, which is a systemic disease and associated with glaucoma in 30%. usually ipsilateral to the facial hemangioma, and ophthalmus in 60% of the cases. Usually the cause of the glaucoma, either it is rise of the pressure, episcleral pressure, venous pressure, or angle anomaly could be responsible. Neurofibromatosis also is a phacomatous, and usually ipsilateral to the neurofibroma of the upper lid in 50% of the cases. Usually angle neurofibroma or angle anomaly is the cause. The impact of the visual on the visual development could be extreme. So early recognition and treatment can save the life as a visual future of the child and the lifestyle of the whole family. Usually the classic manifestations, the parents usually come complaining the child may have epiphora, photophobia, blepharospasm, or large size of the eye. Ocular examination is done, full ocular examination, but we focus on the corneal diameter. Usually it's less than 10.5 at birth, corneal edema, and through it we can detect or classify the degree and the severity of the disease. Tonometry, as Dr. Tariq said, we use Perkins tonometry, tonopen, or we use the eye care, and we examine the fundus and check the cupping, which is sometimes reversible in congenital glaucoma cases. We should put a differential diagnosis for if the glaucoma appears early, breast trauma, congenital anomalies of the nasolacrimal duct, congenital clouding of the cornea, infections of the eye, megalocornea, Peters anomaly, posterior polymorphous corneal dystrophy, and sclerocornea. The treatment of primary congenital glaucoma is almost always managed surgically. This is very important. Medical therapy, the role is usually temporizing the measure prior to surgery, or in some rare cases, if it's late onset of the disease, in secondary cases, we can use the medical treatment. But for the primary, it's almost always congenital, surgical. Surgical, as Dr. Brookes said, start with the goniotomy, trabeculotomy. In Egypt here, most of the cases are severe and come with cloudy cornea. So we are not able to do a lot of goniotomies here. So we do trabeculotomy or combined trabeculectomy, trabeculotomies, or deep sclerectomy recently. And when these fail, we go for tubes. The main topic of my talk is the surgical difficulties that we have during the surgeries for congenital glaucoma. The first one is the exposure of the surgical field, because usually we have a large globe and small palpebral fissure. The second thing is thin sclera, which may cause premature entry to the eye, if we are, premature entry to the eye, and hypotony and lost anterior chamber, how to manage. Identification of the Schlemm's canal, which could be and usually anatomically disturbed and maybe located posteriorly than its original site because of the large cornea. Hyphema during trabeculotomy, how to avoid, and microperforations in deep sclerectomies. Well, for the exposure, some surgeons used a superior rectus traction suture. For me, in congenital especially, I use peripheral corneal traction suture, which gives me better view. For the thin sclera, I usually have a large magnification. I use the crescent knife or the diamond crescent knife, high magnification and dry field, and try to be in the same level during the whole of my dissection. If I have a premature entry, I usually inject an air bubble, which usually is sufficient. And I always take a pre-placed 10-0 nylon sutures at the edges of my flap before I enter the eye, so that if I have sudden loss or I have any problem, any problem during like hypotony or bleeding or something, and I want to close the eye quickly, I have the sutures already placed. I just have to tie them quickly. We can use also different types of viscoelastic material if I have a premature entry, or even during I take the corneal traction suture, maybe you can perforate. So inject the viscoelastic and proceed with your surgery, but avoid using the mitomycin in such conditions. Identifying the Schlemm's canal. For the trabeculotomy, I use the super sharp at the junction between the cornea and the sclera. just above the trabecular meshwork, and try to make small incisions until you see blood or oozing of fluid. And usually this is the size of the trabecular meshwork. And for the deep sclerotomy, you with the deep flap, you can identify it, and then also during the trabeculotomy, you can introduce proline suture to identify the track where you are going to use your trabeculotome. Here is video for a case of deep sclerectomy, case of congenital glaucoma. Here I take the corneal traction suture. I use 7/0 nylon, or sometimes I use the 8/0 vicryl. I pull the eye inferiorly. I do periotomy. I do release incisions. I have good exposure. Cauterization. If you have a bleeder, cauterize it. Don't use excessive cauterization. In this case, I just after there was still bleeding, I just compress with a Q-tip or with a sponge, and it was enough. I do my flap and dissect using a crescent knife. Here, I do high magnification, dry field, so that I can have good visualization. To the cornea, 2 millimeter, to have a good distance between. I put mitomycin and I wash it copiously. Then I do my deep flap. And I dissect it just above the choroid. This is the key point to reach the Schlemm's canal. If you cannot reach the Schlemm's canal, you can have a third flap. So if it's not deep enough, go ahead and do a third flap until I start seeing the oozing of the aqueous. Here I try to remove the floor of Schlemm's canal, but mostly I cannot find it. Maybe it is removed with my flap already. I take a pre-placed suture here, so that when I cut the flap, the deep flap, maybe I have a perforation, so there will be hypotony, and I should have my pre-placed suture. I can close as fast as I can. Here I am removing the deep flap using Venice. And closure of the flap with 2 sutures at the angles, and closes the conjunctiva with inverted flaps, watertight. Sometimes I inject heel fluid under the flap and under the conjunctiva. Okay, this is this is another video for trabeculotomy. Here, trabeculectomy and trabeculotomy. I dissect. I put mitomycin also. For 2 minutes, 4.2 milligram per ml for 2 minutes. I remove it, I wash copiously. Then here with the super sharp, at the junction of the gray and the white line, I try to make small incisions. I identify the Schlemm's canal here. I introduce my proline suture. Here, I see the oozing. And this is my trabeculotome. Should go easy, avoid false passage. Right. On the left. At this point, I always do paracentesis in my glaucoma surgery, and I inject viscoelastic, so that when I do my trabeculotome, the iris is away, and I avoid, and it compresses and avoid bleeding. Here I do my trabeculotomy using Kelly punch, and peripheral iridectomy, and closure using 10/0 nylon. And here is my conjunctival closure, watertight. Thank you very much.
Thank you, Ahmed. That was excellent. Ahmed is the director of the glaucoma unit in the Memorial Research Institute and the director of the new clinic in Mike. I have a lot of pleasure in working with Ahmed, and I've assisted him in a lot of his surgeries. He's a brilliant surgeon and then a great leader for this new endeavor. From there, we go from one leader to another. Professor Hani Nasr is obviously a major figure in ophthalmology in Egypt for a long time. He is a key person who has a lot of projects that rested on his shoulders for years. His actual baby now is the research center of the Memorial Research Institute, and I'm happy to be working under his leadership. Dr. Hani is going to speak to us about tubes in pediatric and congenital cases. Dr. Hani, the floor is yours. Dr. Hani, you need to unmute, please, and then share your screen.
Hi, everybody. I am pleased today to share my experience in tubes with the distinguished expert in glaucoma. As all of you know, that tubes are used in refractory glaucoma. In pediatric glaucoma, I usually use it in congenital aniridia or after penetrating keratoplasty, and in inflammatory glaucoma or glaucoma associated with anterior segment dysgenesis, or if it is a failure of other procedures as trabeculectomy, trabeculotomy, or goniotomy. Mechanism of action to divert aqueous from the anterior chamber to area remote from the surgical limbus, where fibrosis is the cause of failure in many operations. The tubes, there are two types of tubes or shunts or stents, non-valved as Molteno and bevel, which depends upon the resistance of the fibrous capsule formed around the plate, forms the resistance to the outflow. This resistance, fibrous capsule is formed from 4 to 6 weeks. So the ligature, we do ligature to the tube with the Becquerel until the capsule is formed.
Dr. Hani, can you make a PowerPoint full screen, please?
Excuse me?
Full screen PowerPoint.
Okay.
F5.
Okay. Or the tubes may be valved. There are many valved tubes, but here in Egypt, we are the common tubes. The common shunt is Ahmed valve. I use it since 2000. Before that, I used a regulator called Ophthalmic glaucoma pressure regulator in 1996 to 1997. It's no more exists in the market. And there are other tubes like Kluppen-Denver valve, or recently the eye watch, which you can control the intraocular pressure by a magnet watch. I'll share you my experience from 1995 in two regulators I use, Ophthalmic glaucoma pressure regulator and Ahmed valve. If we compare both these two regulator, the Ophthalmic is very small, about 17 millimeter in length, and the regulator is 5 millimeter with wedge to sutures, and its shape is like toothpick, while Ahmed valve is shaped like a computer mouse. The mechanism of the regulator in Ophthalmic glaucoma pressure regulator is 180 micropassage way accept the reduced pressure aqueous and through its inherent conductive resistance regulate pressure between 8 to 19 millimeter mercury. While in Ahmad valve, there is the membrane, silicone elastomer membrane, which it's 7 to 8 millimeter, acts as a venturi shaped chamber adjusted to open and close between 12 and 14 millimeter mercury. This is the shape of optimal glaucoma pressure regulator. And this is one of the cases I did. I did about 20 cases. I did a paper in that in 1996 about this regulator. It's formed of inner inlet tube formed of PMMA and outer tube formed of silicone, and at the end the regulator is 5 millimeter with the edge for suturing is formed of silicone. And this is the interior design of the Ahmad valve, as all you know. In optimal glaucoma pressure regulator, this is the 180 micro passageway that control the intraocular pressure and adjusted between 12 and 13 millimeter mercury. Ahmad valve in Egypt, really we have just S3 for pediatric use and S2 for adults, and FP7 and FP8 for adult and pediatric. The difference in that the plate here is formed of PMA and the other plate is formed from silicone. As we all know that tubes is not without complication. The most important complication and most hazardous complication is hypothony. Hypothony occurs from overfiltration as a result of leakage around the inlet tube or a result of valve failure. This hypothony can lead to choroidal detachment and choroidal hemorrhage. Also, the tube can cause corneal decompensation from touching the corneal endothelium. So you have to adjust the inlet tube to be between the cornea and the iris, midway between them. Recurrence or increased intraocular pressure occurs in tubes due to fibrosis, excessive fibrosis around the regulator. This can be avoided if you have a scleral patch. You can put it on the regulator. I show you this first film of congenital glaucoma using optimal glaucoma pressure regulator. The quality of video was not good because it is recorded by an external video recorder, as we have in that time integrated microscope and integrated camera in the microscope. This is another case where I implanted an Ahmad valve in congenital aniridia. An infant 7 months old with bilateral congenital aniridia and corneal opacity. Left eye where the tension was normal. In the right eye, the tension was 35 millimeter mercury. In the right eye, I did trabeculectomy with mitomycin, which failed. So I did another operation, trabeculotomy with trabeculotomy, and failed also. And these two operations led to corneal decompensation and corneal opacity with complicated cataract, and the tension was 30 millimeter mercury. So the is made to do combined keratoplasty, irrigation aspiration, PMA IOL, and Ahmad valve implantation. The post-operative cornea is clear, IOL in place, and intraocular pressure was 10 millimeter mercury. At the end, I ask you to share with you our dream, as Dr. Tariq said, for our research center, which was done and constructed in 2018. Our dream is to do a genetic lab. We have a genetic lab now, which is equipped with sequential genetic analyzer, gel electrophoresis system, nucleic acid extraction system, and real-time PCR. I will show us a small film about 1.5 minutes for this, our research center. Thank you.
Thank you, Dr. Hani. That was excellent. It's I think you take us into a journey of throughout your experience, and I think the other speakers and the audience will have a lot of questions for you. We finished the glaucoma part with Albert speaking on the use of lasers in children, and I'm very interested to hear what he's going to say. People usually leave lasers as a last resort, and that is basically the conventional wisdom. I guess we will understand more about the role of lasers from Albert. Albert, thank you very much for being with us tonight.
Thank you, Tar. It's a pleasure to be here. I want to thank you and the organizers for including me on this. And I want to I don't want to elaborate on this, but I want to really congratulate you on the concept of Mike. I think in the region, there's really not much to talk about in terms of children eye hospitals, and I wish you all the best and the success, because this could be this could change the way we treat children in the region, where often they're treated as part of in adult clinics and adult hospitals, and it's definitely not the same type of care. So I will be talking to you today about laser treatments for childhood glaucoma. Those are my disclosures. None of them are directly related to the topic of tonight. And as my fellow colleagues already described, childhood glaucoma is a surgical disease, and we go through this surgical algorithm, which starts with minimally invasive procedures, goniotomy, GAT, ab-interno approach, trabeculotomy when the cornea is opacified. Then we escalate to more, incisional surgery, and often we end up failing in not an insignificant percentage of these patients, unfortunately. And childhood glaucoma is not one disease, it's a group of diseases. Even with PCG, there's a spectrum of disease. And some patients present advanced and the cornea, the eye is ophthalmic, and we go directly into ciliary ablation. Cryo is mostly historical, of historical significance. We've been using diode transscleral lasers for decades. And more recently, we have the micropulse CPC, which I'm happy to share with you some of our experience with it. This is basically a short review of what we know in two papers, and not surprising to see one of them from Saudi Arabia. As Tariq mentioned, in the Middle East, childhood glaucomas are prevalent and they're more severe. And you see the trend both in the Saudi paper and from the experience in Australia. The success tends to drop over time. I mean, this is a chronic disease that children grow up with this disease, and invariably we lose IOP control in some of those patients over time. At Rutgers, we're a referral center for childhood glaucoma. Children who underwent goniotomy and trabeculotomy and fail with progressive disease end up with cilioablation with diode laser, with a CPC. And this slide summarizes our experience. It's a review from a few years ago that we presented at ARVO. And I wanted to highlight the fact that with laser treatments, we did deliver energy to the ciliary body, and we often extract our experience from adult cases, which does not necessarily apply in children. But I like to talk about the total energy that we delivered during these lasers. So those were the average parameters in our series. We treat with long durations. The mean was 3 seconds, but most recently we treat almost uniformly with 4-second duration, power around 2000 milliwatts, and about 8 treatments with a conventional CPC, continuous wave, per quadrant. So an average about 24 treatments per eye. So this equates to about 100 joules, and you will see that that number comes up often in the presentation. The problem with CPC, although it's successful, is its complication rate. I mean, those are sick eyes with advanced disease, but the literature is not rich on this topic. Most of what we learn from retrospective series, which is not high-level evidence, but it is what we have to deal with. And in most of the literature, we see that often those eyes require more than one treatment, actually multiple treatments often. The problem with this disease being so variable and a spectrum of disease is you see the success rate varies. With one treatment, typically the success is less than 50%. And as these eyes are retreated, the success rate could go up in terms of IOP control. The problem with doing that is the complications that you get with continuous wave laser treatments. Hypotony, retinal detachments, choroidal detachments, so on and so forth. So you're walking this fine line where you want to deliver enough energy to have an effect, but if you overdo it, you end up with big complications. And here's where micropulse came into the picture. In concept, it's a milder treatment because you're delivering less energy. I know many of you already have experience with this, but just briefly for the juniors on the call, micropulse is basically a laser technology where the laser goes on and off in duty cycles, so it's not constantly on. And the literature on micropulse for adults and children is also evolving. There's not much on there, and I'll share what we've learned so far. The parameters are constantly changing as we learn more about how to use micropulse lasers in adults and in children. This is a review of energy dose response with micropulse lasers. And you see here there's a knee effect in terms of the blue columns are eyes requiring retreatment. So the odds that eyes would require retreatment goes down as you approach that 100 joule energy dose. And if you exceed 150 joules, that's where the risk of complications starts to increase. So you want to land between that 100 and 150 joules, typically in adults, to get good effect and avoid complications. This is an editorial from the Blue Journal by Harry Quigley from Hopkins on micropulse lasers, and this was in last month's journal, so it's fresh out of the press. And he really highlights how all these new technologies, and I know Dr. Brookes briefly touched on that with MIGS in children and using these devices. With new technology and with a tough disease, we're eager to embrace new technologies, but we have to always keep in mind and understand that the level of evidence with these new technologies is very limited. For example, there are no randomized clinical trials for micropulse therapy currently available. So, this technology has been adopted. The company claims it is safe and effective, but as physicians, we have to ensure that that is the case as we adopt it, particularly in children, where they have a longer life expectancy and chances of error should be minimal. I'm happy to tell you that with micropulse, there's not much literature, but a significant amount of the literature is from Egypt. This is a paper from Mansoura University where they did micropulse on pediatric glaucomas. They had 36 eyes, 16 years or younger, so some of them included juvenile glaucomas. They're not all PCG. Treatment parameters are listed on the slide. Pressure reductions were significant, and 2/3 of the eyes required basically 2 treatments. Number of medications also went down. Now, this is the Kaplan-Meier curve from that study that compared outcomes in different groups. I point that 7 out of the 36 required subsequent surgery. the survival for MicroPulse was short-lived also at about 9 months. And that's a theme that you will see repeated in a lot of these papers. This is another paper from Cairo University, 45 eyes, 12 years or younger. Some of those eyes had prior treatments with continuous wave. But you see here what they did was they compared MicroPulse with continuous wave, which is the older way of delivering, and the laser. And they looked at success criteria and safety in those eyes. And that's the Kaplan-Meier. And MicroPulse here did well. Success rate was significant, 71% of eyes. It was higher than the continuous wave arm. However, the eyes that were treated with the MicroPulse, a significant percentage of them had already prior treatment with continuous wave. So those were not virgin eyes. And the rates of complication were low in the MicroPulse arm, although in this paper, there was one eye that developed ptysis. So you could still get significant complications even with MicroPulse, albeit it's safer than continuous wave laser delivery. This is, again, a very small study from China, 9 eyes, only 1 PCG. So a lot of the eyes were secondary childhood glaucomas. They delivered 200 joules of energy, and yet the success was not as one would expect in adults. The pressure reductions were there, but they were short-lived, and the pressure tended to rise after 12 months. The majority of the eyes required additional surgery. At Rutgers, currently, we have an ongoing study where we're comparing MicroPulse to continuous wave. Again, the reason for the MicroPulse is the theoretical or hypothetical safety value of it, because you're delivering less energy into those eyes. The mean pressures were high in both groups, but the continuous wave was higher. And our treatment algorithm evolved shortly after, because the company gives you guidelines on treatment, but they're mostly adopted from adults. So we modified them for children. We went more conservative in children. But I noticed very quickly that the effect was very short-lived. So we had to increase our duration of treatment from 3 quadrants to 4 quadrants, which is what we're doing now. Currently, there's a new probe that was launched where you treat by hemispheres, and we're still learning about that dose response, and we're developing our algorithms as we do that. One lesson I learned very early on is to avoid ointments that are not clear. For example, our hospital provided us with Tobradex ointment as a coupling agent for the surface of the eye. And I noticed in eyes that underwent MicroPulse laser treatment with Tobradex as the coupling agent between the probe and the surface of the eye required a much higher retreatment rate. And that was because I think the hypothesis is that a lot of the laser energy gets dispersed by the crystals in the ointment rather than being delivered into the ciliary body. So going back to that curve that we talked about, we're trying to aim at about 100 joules, and currently you deliver that either per quadrant or per hemisphere. But there is definitely a dose response curve with the MicroPulse laser, and it's evolving. We're still learning about it. I titrate it now to deliver about 100 joules of treatment per eye. And so far, we've had good response, and safety-wise, we've also been doing well with almost no complications in the MicroPulse arm. So just to conclude, MicroPulse has a role in childhood glaucoma treatment, but you have to take into account that younger patients heal very well, and they get inflamed more. So, and you rely on parents to deliver the steroids as anti-inflammatories. So anytime you deliver a laser energy that could cause significant intraocular inflammation, I rely on subconjunctival steroids, just in case the parents do not adhere to the treatment regimen. so you would avoid the risks of hypotony or ptysis. You have to use a clear ointment to couple the laser probe to the surface of the eye. Lidocaine jelly works really well. The company that makes the MicroPulse came up with a new design for the probe, which I think is superior to the first generation probe. It's much more ergonomic. The tip is smaller, so it fits better on the surface of children's eyes. And all the variables, including the power, duty cycle, and sweeping speed as you sweep that probe on the surface of the eye, are variables that you have to control as you deliver those treatments and as you develop your own algorithms for how you treat those eyes. So the dose energy response is still to be determined in children. Surgery remains the mainstay, and we often have to go to these ciliary ablation treatments when glaucoma is refractory. And I still think MicroPulse has a place, and it seems to be safer than continuous laser delivery, but we have to develop those algorithms and validate them as we go forward. Thank you.
Thank you, Dr. Khoury, for this informative presentation about this new technique. Actually, we have the MicroPulse in our institute, so, and we have done about like 25 cases, not only congenital, we did for adult also, so we have it here. Well, now we just inform all our attendees that we'll answer the questions at the end. So because we have some questions, so just be patient with us if you allow us. Now we'll have Dr. Nader will give us a talk about the multidisciplinary approach for congenital glaucoma patients. Come on, Dr. Nader.
So you are seeing my screen now?
Yes, Nader, it's fine.
Okay, it's now 11:35 p.m. Cairo time. Good afternoon, dear professors, doctors, and colleagues from Egypt and from all over the world. It's a great honor to present in front of pioneers of glaucoma surgery in the world. Today I'm presenting how we document cases at MIC. I have no financial interests. So in this presentation, we will discuss the dark side of the moon, a multidisciplinary approach, and how we document cases, and we will discuss our MIC protocol. So in the year 1973, there was an English band, an English rock band named Pink Floyd, with the album talking about the dark side of the moon. So what's the moon? Is the successful surgeries for pediatric glaucoma, and this is the dark side. This female child was presented to our MIC with completely lost left eye. Almost the vision was PL due to multiple glaucoma surgeries, and deeply amblyopic right eye just because of only surgeries and without the multidisciplinary approach. So a multidisciplinary approach is needed, and as we see here, the glaucoma fellow with the pediatric ophthalmologist working together and other members of the team. So treatment absolutely requires a multidisciplinary approach, said Dr. Peter Netland from USA, and you must mobilize your whole team. In MIC, we document cases. We receive 1 to 2 new cases per week, and this is our reception. And the residence, this is the childhood glaucoma sheet. And I would like to say that the most important things in the sheet are the risk factors, as the major studies in Egypt talking about the risk factors influencing the outcome or affecting the outcome. The first risk factor is the corneal clarity. As said before, most of our patients came late with severe cases of corneal opacities, opaque corneals, hazy to opaque corneas. The second group is the early age at presentation and the high preoperative IP. And the third group is the female gender, positive family history, and positive consanguinity. This is a major study done in Egypt, published last year in the British Journal of Ophthalmology, talking about the factors influencing the outcome of angle surgeries in PCG, done on 452 eyes, and the previous risk factors were identified. We measured the IP using the new iCare 200. That's pressure, that's position, give the position freedom, whether to use it erect or supine position. And we are aware that using the iCare may increase in the measurement the mean IP by 2.3 millimeters of mercury. We also use the Perkins tonometer, and we use the tonopen in cases of scarred corneas, opaque corneas, or thick central cornea thickness. There is a tension between the need of repeated anesthetics to allow sufficient monitoring and treatment of the disease and the concern of possible deleterious effects on the young brain development. So we do not do many examinations under anesthesia. And we use the milk sedation, like lactating the babies. And we use chloral hydrate, and we use ketamine hydrochloride intramuscular injections to use. So we use it to measure the IP, and we all know that ketamine have almost no effect on the IP. If we needed to do examination under anesthesia, again, a multidisciplinary approach, and we use the Perkins tonometer upon induction of the general anesthesia to measure properly the IP, and we consent the parents that if we confirm the condition, we will do the surgery in the same setting of the examination under anesthesia, so that, again, no repeated anesthesia. And then we classify the patients into glaucoma or glaucoma suspects according to these definitions. Glaucoma if the IP is more than 21 millimeters of mercury with optic disc cupping and cupping asymmetry of more than or equal 0.2 with focal rim thinning, corneal findings and enlarged corneal diameter, progressive myopia and visual field changes in cases older children, and almost our children are very young. And then we have the genetics clinic case sheet, and we do the genetics consultation, as Dr. Hani said, in our genetics unit, so that we could predict the risk factors or the risk of development and the choice of the surgery that will affect the results. And then we classify according to this classification, the primary congenital glaucoma, the childhood glaucoma, and the secondary childhood glaucomas associated with several anomalies. And then we discuss cases. Some discussions tend to be hard like this. This is a classic example of a patient coming to our mic with bilateral enlarged corneas. You can see that the right eye has central opaque cornea. Most of the patients, the parents, say that, wow, my child is having big, beautiful eyes, and they just come when the color become bluish or cloudy corneas. So this is our MITE protocol. That's mainly for the PCG, the primary congenital glaucoma. According to the severity of the condition, we classify the patients into mild, moderate, and severe, according to the major identified risk factors in Egypt: the cornea clarity, the early age at presentation, and the high preoperative IP using millimeters of mercury. Mild cases with clear corneas and the age of more than 2 years old and less than 25 millimeters of mercury. We do for them trabeculotomy 180 degrees. I know that 360 degrees was discussed earlier. We are aware of the GATT technique. We use suture with proline in other types of glaucoma, but not for the primary congenital glaucoma yet. we need to have more cases to be done in a study in Egypt population. Moderate cases with hazy corneas and the age from 2 months to 2 years, and the IP of 25 to 35 millimeters of mercury. We do the standard technique, as Dr. Tariq said previously, the combined trabeculotomy, deep sclerectomy, and as Dr. Ahmed Duwidar said, the combined trabeculotomy as a second option. Most of our cases, 90% or more, come with the severe condition, the opaque corneas, very early age at presentation, at birth to 2 months, more than 35 millimeters of mercury. We do the surgeries as moderate, and as Dr. Khoury said, we tried the micropulse diode, but with the gentle duty cycle, or other name is the low duty cycle, 25%. And this is the device that we used as doing micropulse to decrease the IP for later surgeries, so that the survival, Kaplan-Meier survival time will be higher. Usually we do the follow-ups every 3 months till the age of 18 to be discharged from our mic to continue at the Memorial Institute, our institute adults glaucoma department. We refer cases to the pediatric cornea, our pediatric cornea department, with having severe corneal scarring or cloudness, opaque corneas, so that they could do further interventions like keratoplasties or something like that. As a conclusion, we say to the patient that and his parents that you will never walk alone. We have a multidisciplinary approach, and we will be very happy to share the experience with many surgeons all over the world at our mic. And thank you very much.
Thank you, Dr. Nader, for this presentation. Now, Dr. Heba will give us take over now from us. We finished our role now, and now she, as a pediatric ophthalmologist, she take over. You can tell us.
Just before you start, I wanted to thank Nader for his last slide showing that you never walk alone. And I'm very happy to announce that Liverpool just won the Premier League a few minutes ago. So it's
very recent.
in perfect timing for us. And
Dr. John, you are a Liverpool fan or what?
I'm a very big Liverpool fan. So you finish here and they'll go in the streets and celebrate. But I wait to listen to Heba first. Heba, please.
Thank you, Dr. Tariq. Congratulations for Liverpool. And thank you, Nader, for summarizing and presenting our protocol in the Memorial Institute Kids Eye Center. From your multidisciplinary talk, I will talk about a multidisciplinary approach in another way. Because I think that the relationship between the pediatric glaucoma and the pediatric ophthalmologist is a non-stop back and forth relationship. I think you need me in all your cases, and let me tell you how. You cannot have successful outcome with successful surgery only. You need my visual rehabilitation, follow-up of patients, and amblyopia therapy to have this happy end. And to avoid this miserable end, the end of having severely amblyopic eye, strabismus, complicated cataract, and finally, the most miserable blind eye with successful surgical technique. Because the visual outcome is not just related to the surgical technique or even the medical therapy. It is related mainly to the visual rehabilitation in the first years of the child's life. Actually, in the first 3 years of age, there is a rapid change of the axial length of the globe, and with increased IOP and the soft globe, a high myopic shift, very rapid, would happen. In the literature, it is well proved that the patients with a very low and poor visual outcome were associated with a rapid and severe myopic shift. also in the literature, in all studies, was to search for the visual outcome, the long-term visual outcome after primary glaucoma surgeries. There's almost 50% of the cases had a good visual acuity if they had a good visual rehabilitation, and only 30% with moderate visual acuity, and only the 19% of cases was with poor visual acuity if left unmanaged by the visual rehabilitation, refraction, and amblyopia therapy. Again, you need me in the examination under anesthesia. You cannot make the examination under anesthesia without me. On the other side of the truth, many decisions of my decisions depend on you. Actually, the incidence of the patient develop pediatric glaucoma after the pediatric cataract surgery is 13%. So I would need you in some of my cases after I do the pediatric cataract surgery for my patients. And also in the patient, if the FRCOphth patient developed glaucoma, I cannot implant secondary IOL without having your decision and your advice whether to implant or not after controlling the IOP. And if I had a patient with aniridia cataract, most probably up to 70%, 75% in the cases, I would need your help because patients would develop glaucoma after removal of the cataract. And in this very silly situation, the microphthalmia with crowded anterior segment, if I succeeded to do the cataract extraction for my patient without IOL implantation, and I succeeded to do the surgery, and the patient passed without having any FRCophth glaucoma, I would never implant for this patient except after your advice and examining of the angle. And if I implant the patient and I correct his aphakia after a long time, the patient would develop also pediatric glaucoma, and I would need your help. In some of the cases with the anterior segment dysgenesis syndrome, I do the gonioscopy, and sometimes it is suspicious, and I need your help and decision without going ahead and do my cataract surgery with special considerations with the angle closure. And finally, I think I need you as well in most of my cases, and because the relation between the pediatric ophthalmology and the pediatric glaucoma is a non-stop back and forth relationship. Thank you for all your very, very nice talks. And from my talk, I'd like to raise a discussion about many points in your very nice lectures and presentation and talks. Thank you for you all, and I will leave Dr. Ahmed Duwidar to raise the discussions and answer many questions on the Q&A box. Thank you.
Well, Dr. Tariq, I think you are ready now. Or
I'm happy to share with you the question and answer session.
yeah.
There's a question for John. John, one of the participants is asking, what happens if you have a failed trabeculotomy? What would be your second operation after that? Would you repeat a goniotomy? Would you repeat? I'm sorry. So that your failed goniotomy, I guess the question is trabeculotomy, but I guess it's what happens if your goniotomy fails? What would be your next step?
So when I used to do goniotomies, it would be a first goniotomy. If that failed, then repeat a second goniotomy, and then proceed to a bare belt tube. With the advantage of the 360, there's no point in repeating the trabeculotomy because the entire angle's already been opened. So if that fails, unfortunately fewer and fewer do nowadays, but if the 360 trabeculotomy fails, I would go straight on with the bare belt tube implant.
Okay. Now, I kind of share your opinion about the GAT procedure, and my major concern is always the learning curve and how many surgeons, how many glaucoma fellows will be able to train in this technique that is significantly more challenging than an ab external approach. Is that why you are leaning more to the ab external versus the ab internal, or are there any other issues related to that?
Well, I think ab externo, after several cases, because we're sort of used to dealing with the conjunctiva and the sterile flaps and this sort of thing, there is a learning curve to it. I believe there's a greater learning curve for the GAT. I think if you are trying to do both, if you have it depends on the corneal clarity. If you do the GAT, you may have in certain circumstances have to do the ab externo. So with the ab externo, what I'm trying to say is that you can do it for all cases. So you only have to use one procedure, whether the cornea is clear or not. So for training, repeatability, corneal clarity, the fact that you are operating on the conjunctiva, that you're well away from any future site for tube surgery.
I think you make a very strong case. It's not just about ease of use, but it's also about that with an ab externo approach, you can address different stages of the disease, while with the ab interno, you are relying completely on having a good visibility for the angle. Albert, there's a question for you regarding how did micropulse change your approach to congenital glaucoma in general in your practice?
You know, the micropulse experience is, I would say, maybe 2.5 years old. And initially, I was a lot more enthusiastic about it. I thought it was going to work as well as continuous. And I've been disappointed, but I think that is mostly because we do not know how much energy to deliver to those eyes. I think as we get better at that, our success will likely be better. I can tell you a specific case, for example, where I had a baby come in with a cloudy cornea, have striations that had ruptured, and the eye was the cornea was very opaque, and the family was leaving town. So under normal circumstances, I would have done, you know, an ab external approach like a trabeculotomy, or I would have attempted a 360 with a suture. But in that case, I didn't want to cut into the eye and have the parents leave, so I did a micropulse. And the baby came back 2 months later with a clear cornea, and I did a goniotomy after that. So I think it's a good tool to have. It could save us a lot of times in sticky situations, and it seems to be safer than continuous.
But you wouldn't call it a game changer?
Not at this stage, because we do not know what we should do at this point.
I mean, you'd agree with me that whenever you have something new that is introduced in your armamentarium, you go into cycles of enthusiasm and disappointment, and then you can maybe polish your knowledge, and you go into another you know, peak of enthusiasm. And we speak about peaks a lot these days.
100%.
Ahmed, there's a question for you about Sturge-Weber syndrome. What would be your favorite approach, or your surgical approach of choice?
The video in my presentation of deep sclerectomy, this was a Sturge-Weber case, actually. This was a Sturge-Weber case. So I prefer deep sclerectomy, and be cautious, of course, not to have a premature entry or to injure the choroid. I will go for deep sclerectomy. I think it's safe.
Deep sclerectomy is associated with early hypotony in the first week. That doesn't worry you too much when you're doing a Sturge-Weber?
Most of the glaucoma surgeons will have hypotony. So I think maybe I will inject some viscoelastic at the beginning, just to maintain the pressure in the height a little bit high for the first 2-3 days. But I go for deep sclerectomy, avoid opening the injury to the sclera or the choroid as much as I can, I think.
I actually share your opinion about Sturge-Weber, and I've been invited to King Hussein Military Hospital in Jordan many years ago, where they had actually prepared 6 cases of Sturge-Weber, which has been a personal record to operate on 6 Sturge-Weber in one day. That must have been years ago. Dr. Hani, we have a question regarding big insisted blebs on top of tubes. How would you manage cases like that? I mean, these can be very challenging, and in children, those blebs can be very prominent. They can be almost as big as the globe in some cases. So how do you manage those, Dr. Hani?
If the intraocular pressure is high or it is normal,
Usually it's high. With a bleb like that, the pressure would be high.
we have to interfere either by needling or by opening the conjunctiva and removal the fibrosis which is around the plate.
Anybody wants to add or share experiences about that? Because I agree with Dr. Hani. When I saw those cases, I sometimes needled, I sometimes excised tissue, but I must have been very unlucky because in most of those cases, I ended up having to remove the tube altogether. But I'm curious about John and Albert's experience in that.
Yeah, I mean, I've tried all of these things, needling and removing the scar tissue, with very low success. If you do excise the scar tissue, it actually regrows very quickly and you're back to square one. These are generally armored valves, I find, that cause the big encapsulation over the plate. And they've usually migrated a bit anteriorly. So in the end, I generally have to remove them and then replace them with a bare belt tube if pressure's still a problem.
Albert?
I agree, and I've seen this in the US, mostly in African American patients, babies, where they, just like in adults, they encapsulate so hard and they have a lot of fibrous tissue. Most of the time it's disappointing, but again, I would go through the algorithm. I would needle first with mitomycin, and if that does not work, I would excise and I would leave the removal of the tube as a last resort. I've had few cases where excising Tenon actually worked and the bleb flattened over time, but it's a limited experience.
Yeah, I think.
Dr.
Yes, please, Ahmed.
Now, if we have, after needling and we have still fibrosis and the pressure is high, do you think that it is good to have put another tube in another quadrant, so the patient may have two tubes in the same eye?
I mean, this is a matter of opinion from one surgeon to another. I mean, I don't think there's a long or a big longitudinal study to look at multiple tubes. I mean, I've seen a few cases that came from Finland to my service that were operated by my very, very dear friend and colleague, the late Juhani Airaksinen. I don't know, John, if you remember Juhani. When we were residents, he was quite big, and we were studying from his book at that time. And Juhani used to have what we call the Mercedes sign, so 3 tubes in the in the eye. I'm very, very, very wary of putting 1 tube, so I am very skeptical about putting 2, and I would be scared out of my wits to put 3. If I have to put another tube, then I would at least take the 1 out and try another quadrant, but I would not leave many tubes. We've been following patients' endothelial cell counts over years, and the results are quite scary. When I started speaking about endothelial cell count loss like 10 years ago, I remember Keith Barton was saying, no, that doesn't happen to us, yeah, Moorfield's endothelial cell counts are invincible. But I think there's now a conventional agreement that endothelial cell counts, get damaged with time, and people, our elders, somebody like Franz Gran would tell you that if you put 1 tube in a child, you will probably put him through a couple of keratoplasties down the line as he grows up. So I don't know if John and Albert have different experiences with putting a couple of tubes in the same eye.
Well, I mean, with children, you've just got to bear in mind their life expectancy, which is many decades. So you really don't want to do everything early, because you're going to run out of options later on in life. So if a child's had a tube, I would go through the needling, tube flush, I may repeat that. I may do a cyclodiode laser. And really, when all that's been exhausted, then I would do a second tube. I tend to leave the first tube. I understand what you say about the endothelial cell count, but it's sometimes quite traumatic to the eye to remove these because the plate gets very scarred into the eye, and it's quite traumatic and bloody to remove them. But I do take the point, and Moorfield's endothelial cell counts do reduce like everybody else's.
I agree with what you said. When I meant removing the tube, I did not, and maybe I was not clear enough. I would remove the tube, but I leave the plate.
Yeah,
I leave the plate. Albert?
Go ahead, Dr. Hani.
Dr. Hani, تفضل.
Really, I don't like to put another tube. We are adding another foreign body for especially for children. So if the failure, I just try to do needling, excision of the fibrous tissue, flushing, and if not, I remove not all the whole plate, but I remove the inlet tube, and I put another one. I don't leave 2 tubes in the eye.
Do any of you put inferior tubes in children? Have anybody tried that? I've never done that. I don't know if any of the speakers have put inferior tubes in.
No, I
inferior
didn't.
quadrant tubes in children.
Well, in fact, the infranasal quadrant is the second place I would put it for a second tube.
Okay.
So obviously the first preference is supratemporally. The trouble is, if you have a 350 Baervelt, you can't then put another tube in the supranasal quadrant. I think the worst position is in the inferotemporal quadrant because there's lag of the lower eyelid and you get exposure. When it's infranasal, the plate still there seems to be enough space for the plate to be well covered. And cosmetically, it's better. The child has difficulty rubbing that part of the eye as they would temporally. So if there's a 350 supratemporal Baervelt, my next position would be infranasal.
A question to Heba, actually. You've made it clear how much we need you, and I am not going to go against what you said. I totally concur. But would you recommend that for every, at least for the first examination under anesthesia, for a child that has that is a suspect of congenital glaucoma, would you advocate always to have a pediatric ophthalmologist with the glaucoma specialist in the first time that you examine a child? Heba? I don't know if Heba can hear me. Okay.
Hi, Dr. Tariq.
Did you hear my question?
Yes. No. I had a problem in the internet. I just fixed it.
No problem. My question was, would you recommend that for every first examination under anesthesia for a congenital glaucoma suspect, that a team of pediatric ophthalmologists together with a glaucoma specialist would do the examination together? Is that what you are recommending?
For every case of suspect of congenital glaucoma, suppose that you had a large cornea, and those patients would have refractive error, which would have myopia from the first moment, and so I need to. I do recommend. I strongly recommend that in every general anesthesia by the glaucoma specialist or consultant or pediatric ophthalmologist to be there. We can spare the patient for another general anesthesia, general examination under anesthesia, and having the general anesthesia again to re-examine the patient. So I do recommend strongly for the general examination under anesthesia to be a teamwork from the first moment.
Thank you. I think I agree with what.
I want to ask a panel a question.
Please.
If I have a patient with a pediatric aphakia, and then the patient developed glaucoma, and then it is supposed that you that the patient one of the glaucoma surgical techniques to have it controlled, the glaucoma controlled. When do you suggest that I need to implant the secondary implantation? Would I postpone the implantation for 6 months after the surgery, 1 year, or What is your opinion about?
John, do you want to answer that? John, do you want to answer that? Can you?
Yes. So, you know, in fact, if children with aphakia have developed glaucoma, I always try to dissuade parents from having a secondary lens implant and see if they can persevere with either spectacles or contact lens, because I just feel that if you've got a trabecular meshwork that's compromised and then you're putting a secondary implant in as well, you may further compromise the trabecular meshwork and then may exacerbate the glaucoma. If it's essential that they have a secondary lens implant, it probably needs to be as far a bigger gap as possible, really, from the time of the glaucoma surgery. So at least 6 months, I would say even longer perhaps.
It makes perfect sense. I would like to ask Nader. Nader, you gave a very, very nice talk. I really enjoyed it. I mean, in a few years, you'll probably be at the helm of what you are working to create now. And my question is, can you give us a few words briefly, be as brief as possible because we're running very late, about your experience as a fellow in Mike? I mean, is that something, what is the good thing about it and what is the bad thing about the fellowship in Mike? And don't be afraid, I'll protect you. So if you want to criticize,
I am peaceful, Dr. Tariq. I am peaceful. I am peaceful, Nader. Don't be scared.
Well, the place is very promising. We have the consultants, we have the juniors, the mid-seniors, and the seniors. When you have a place where there is a flow of patients and the place with a research, genetics center, it's a training job, not just when you finish your residency program, you just end everything, but we are continue learning until being professors. We share experiences with the other centers in Egypt and in the region, and many national and international meetings. And now it's very easy by the Zoom webinars. Most of us travel outside to gain experiences and then come to serve Egyptians. I do recommend anyone to work in a team like Mike. Well, this is my institute. I think my words will be not fair.
Thank you, Nader. This is
and I learned a lot from you, Dr. Tariq. When
well, I remember when I assisted you. When I assisted you for your first deep sclerectomy, I was afraid that you will get a heart attack. So that I remember quite well. So actually, Nader spoke about international collaboration. One of the reasons that we had Jean and Albert here was to attract those two giants in our field to be somehow in collaboration with Mike. I hope that what they have learned, what they have heard today would attract them to collaborate with Mike. The number of cases of congenital glaucoma in Egypt is enormous. I can promise you that the whole of UK and the whole of New York will probably have, in 1 year what Cairo will have in 1 month. So there's an enormous potential for collaboration between Moorfields and Rutgers, two of the best centers in the world when it comes to congenital glaucoma. I have learned a lot from everybody that spoke today. It's running late, and I thank you very much for giving me the opportunity to be with you tonight. I will hand on to Ayman to conclude, and once again, I thank you very much for your participation, the amount of time and energy that you invested, and the amount of knowledge that you passed on to your colleagues worldwide. We had quite a big number of participants today, and I'm sure that every one of them, I would like to thank you on behalf of every one of them. And I hand on to Ayman.
Thank you, Dr. Tarek. Thank you very much. Thank you to all the speakers. That was an amazing night. I really enjoyed it, and I think the audience also enjoyed it. Well, sorry for the audience for again you'll be beyond midnight in Egypt time. So I would like to finally conclude it, and I would like to stress about what Dr. Tarek had just said. One of the main points in the vision of the MIC is the collaboration with everywhere, all the centers around the world, and of course in Egypt. So we have a big dream, and we'll achieve it. Thank you very much. Thank you for the audiences. Thank you for all the speakers. Thank you, Dr. Tarek. Thank you, Dr. John, Dr. Albert.
Thank you so much. Thank you so much. I really enjoyed this.
Thank you very much. Thank you, all of you.
Thank you.
Thank you for all the audiences. And we're sorry for those who didn't answer some of the questions. But thank you. Thank you. See you next. Keep following our page, our mic page, for the future events.
Keep waiting for the next webinar. Bye-bye. Bye.
Bye-bye.
Thank you.
Thank you. Nice meeting you.
Thank you.